check or,
Yeah.
yeah, exactly.
So this is the bulk of the punctal plug patients at the end of the day.
Right.
And epilation patients, most of them are coming in for a routine. We find this other problem. So.
Right. So in order to bill insurance for any procedure, minor or major, we must document medical necessity. It's up to our doctor to prove medical necessity, and medical necessity is never assumed by any insurance company, Medicare included. They're not going to assume anything in a chart. It's either in the chart or it's not. So it's up to us to make sure that gets proven in the chart. It's got to be very clear so that a claim, not only so a claims clerk and a nurse reviewer can see, and you have to understand that nurse reviewers that review these claims, post these claims, either prepayment or post-payment review, they most of the time know absolutely nothing about eyes. They know nothing about ophthalmology or optometry. They know nothing, seriously nothing. So we need to draw.
She cannot stress how little they know.
So anyway, so we have to kind of make the picture clear in the chart what's going on with that patient. So what do we need to prove medical necessity? First of all, we need a valid patient complaint. The patient comes in for their diabetic eye check, but they complain that their eye is scratchy or whatever. So we need a valid patient complaint. And we need the appropriate exam bullets. So most of the time, that's with the two things that we're going to talk about today is basically a slit lamp exam. We also need the impression or the diagnosis to go along with that. And then we need a plan. And so in the plan, and on the impression and diagnosis, sometimes there's not, may not be one. There may not be a definitive diagnosis, and our doctor still wants to do something anyway, like punctal plugs, but he doesn't have a definitive diagnosis. That's okay. We may not be able to bill for it, but we still document either the complaint of pain in around the eye, epiphora, whatever the case may be. But anyway, and then in the plan, what's the doctor going to do about the patient's complaint? And what did the patient agree to? So this is where if the patient agreed to the surgical procedure, or the ablation or the punctal plugs in there, that's where we would put that. And when possible, a procedure note. Now, we're not going to do a procedure note necessarily for every time we epilate an eyelash. That as often as we do those, that's really not. But when possible, there is a punctal plug note in there.
Yep.
Utilize that, please. On punctal plugs, epilations is such a, I don't know even, that would be we're not going to do that, but at least document it well in the chart. So anyway, we'll talk about how to document that in a little bit. So what does a patient complaint look like? On punctal plugs, like dry eyes, what is, if we're going to do punctal plugs, what does a possible, patient complaint look like?
Scratchy, irritated eyes.
Yep. Very good. And then if, what does slit lamp look, or the slit lamp the findings, exam findings look like? What are we looking at on the?
It's usually always SBK.
Yep. So,
Some of the doctors are better at the tear breakup time than others when it comes to punctal plugs.
yeah. Yeah. That's
So
true.
that's not necessarily required, the tear breakup time, or is
Right.
it required?
No, well, it depends. It depends on the insurance company, honestly.
Right.
Medicare, I think they finally took that out of their policy, and
The
most,
others will follow eventually.
yeah, I think
Okay.
the others will follow. So I don't think we're not gonna,
So if we don't have tear breakup, we're not.
we're still gonna bill it.
Okay.
Because I think very few insurance companies absolutely require that now.
Okay.
But some of them, up until the last few years, Medicare required a Schirmer's.
Oh,
or
I
something
know.
equivalent.
Trust us, we know.
So they finally got smart and took that out of their policy. So anyway, so what kind of diagnoses are we looking at?
I was gonna say, hints.
Yeah, yeah, you could cheat if you wanted to. So these are all of the categories from the Medicare LCD. So they've got your dry eyes, all of your corneal ulcers, like, yes.
This one says pain in or around the eye and epiphora.
Yeah, I'll get to that in a
also.
minute.
Okay,
So these are
jumping ahead.
all of the diagnoses, all of the categories of diagnoses that are on the Medicare LCD for punctal plugs. This is what will get punctal plugs paid,
Okay.
okay? So you might make a note on that slide. Sometimes we just have pain around the eye or epiphora, and we have seen that in a chart where there's nothing documented on we may have a patient complaint and we may have punctal plugs, but we don't have a diagnosis for them and nothing on the exam. If that's the case, your doctor's very generous. And he needs a pat on the back because he's
Doing it
done
for
some work
free.
for free.
Giving them away.
And he's taking very, very good care of his patients, or her patients. So, they get kudos for that, but they don't get any money for it.
Mm-hmm.
So keep in mind that symptoms only, like pain in and around the eye, they will not get punctal plugs paid. They just won't.
Epiphora won't either?
Huh?
That's not really
Yep,
a symptom.
epiphora will not. I just looked it up just to make sure.
Huh.
Epiphora will not get punctal plugs paid because it's just a
But
symptom.
epiphora with keratitis.
Yeah, then now that's a different story. They don't care
Right.
about the epiphora at that point. They just care about the keratitis.
Exactly.
So, another thing that will not get punctal plugs paid is cornea transplant status. If you'll notice, that is not on that list. Nor will status post LASIK. So we gotta have a dry eye. Usually with LASIK, we're gonna have a dry eye diagnosis of some kind. So, but just because they've had LASIK doesn't mean that punctal plugs are paid for. That's another thing. You just pat your doctor on the back and say, "Good job. Thank you for taking such good care of your patient." We document it anyway. The insurance company is not the only entity we have to satisfy. We also have to satisfy OMIC. Anyway.
For those people who don't know what OMIC is.
Okay,
do
so
you wanna talk
OMIC
about
is
for a second?
ophthalmic, ignore that for a minute. Ophthalmic Mutual Insurance Company. That is our malpractice attorneys. Or the insurance company and attorneys, group of attorneys. So they require, even on cosmetic procedures, that we have documented a lot of stuff. So on a medical procedure, we need to document medical necessity. We need to be able to tell the story, whether we're gonna get paid for it or not, what the medical reasoning was behind doing that procedure. It's very important that we have that in the chart, because if something goes south or a patient perceives that something goes south and they contact an attorney and we have to contact OMIC, OMIC's gonna look at that chart, and if we don't have everything documented in the chart, they're gonna say, "You're on your own, see you later, we're not gonna cover this." They're not even gonna go to court with us. So that's a big deal. So we gotta document medical necessity no matter what.
So dry eyes or something like that, keratitis, that sort of thing, that's medically necessity for punctal plugs.
Right.
In addition, your consent should be obtained. So we sit there and the doctor talks about, okay, this plug, it's probably not going to cause you any problems, but if it does, we'll take it out, yada, yada, yada. He or she says that all the time. We hear that a lot.
Mm-hmm.
In that scenario, we need to document patient consent, which is why we print the consent forms. That protects us with OMIC. Yes, ma'am.
So what I've been doing, because when I first started describing, Christine told me to print the consent
Right.
forms, which was awesome. But then what happens is the doctors go through it so fast, and the patient verbally is like, sure, and then right away they put in the punctal plugs. And then by the time I get the printed paper and bring it to the patient, they already have the plugs in, and then I'm like, can you sign this? 'Cause- And then they're like, that's weird that I have to sign this after I got it in.
I just say, you know what, Dr. Mayer was quicker than me, but here's your
But
consent
isn't-
form and you gave approval to sign or
Yeah.
to do the plugs. Would you mind signing this?
Isn't
Yeah.
there a slight delay though? Because don't you have to go and get the plugs?
No,
or are
they're
they
in the rooms now.
No,
Okay.
it's in the room,
Yep.
yeah.
'Cause I was
So
gonna say
I usually
before,
will
it was
say, I'm
always-
gonna grab the consent form. I verbalize that when I leave the room to get it.
Okay.
A lot of times I'll say, I'm gonna grab the consent form while you put in the plugs. And I'll go get the consent and bring it back and say to the patient, even though they already have the plugs in. So this is what Dr. Mayer was talking about, getting the plugs put in. Can I just get you to sign this?
Okay.
Yeah, you still need that signed.
Right, I know,
Yeah.
I just think it's weird for the patient.
It is, but
Yeah.
it's even weirder to make Dr. Mayer sit there and look at the patient for 3 minutes while you go get the consent and come back.
Right.
You know, I'm not trying to be facetious, but you know, with the flow of clinic, and he is pretty speedy. We
Yeah.
all know this. It's easier to just say, I'm gonna grab the consents while you get the
Right.
plugs in, and just say that to the patient, yeah.
Okay,
That's what I do too. I know it's kind of
that's fine, yeah.
a delay, but just dots our I's and crosses our T's.
The most important part is that they sign the consent, right? So you don't have to put in the plan like consent signed or like patient verbalized.
Well, it actually goes in, when you're doing your procedure note, there's a box that you click and it actually goes into the procedure note that consent was obtained and risk and benefits were discussed, and it actually goes into that procedure note that you create.
So I don't have to type it.
Not in the impression plan. If you're doing a procedure note, it should, yeah, good question. Yeah,
But I think ours is different.
might be.
Yeah, like, so you.
For the injection?
Right.
Yeah, so we were talking about punctal plugs.
Right.
That's where my
Right.
brain's at.
On the injection page, I can see it. Like if you hit procedure note and then it does that whole like,
Mhm.
like,
As much as Dr. Cruz wants his note to just say monitor, I know, I heard him.
okay, you heard
You
that.
have to, you still need to put
I
some
should
of
put
it.
consent.
I mean, you don't have to make it sound so long, but I always put like patient understands,
Oh.
something like that.
Yeah.
I heard him. Dr. Cruz is special.
We have that on video. For the notes, that was Sam.
Nothing I wouldn't say to his face.
So our treatment plans, even if we're not going to do punctal plugs in a particular patient, but there's always going to be some kind of treatment plan. So let's, whether it's drops or, tears or NG expression or LipiFlow or punctal plugs, either one. The plan needs to state that, and we really need to state what the patient agreed to. So this is everything he's recommending, and this is what the patient agreed to, because he may recommend more than one of those things. So, what is he recommending? What are all of our options, and what did the patient agree to? So, patient agreeing to that is going to come into play, especially with your question about the consent forms, because they're basically going to give verbal consent. And since they've given verbal consent, you're going to go get the paperwork, and really it should be signed before. But like she said, Dr. Mayer's not going to sit and chat with the patient for 3 minutes and stare at the patient until.
None of them will.
Yeah, no, never will. So anyway, so that would, discussing that with the patient, making sure that gets discussed, and the patient makes a verbal consent as to what they decided to, and that gets in the chart. The patient has agreed to.
Patient elects to proceed with.
Exactly.
We usually do that for cataract surgery anyway.
Right.
So.
So we're gonna quickly go through the same thing with epilation. So patient complaints, what do the patient complaints look like? Basically the same. They can be the same. Slit lamp exam is gonna show this, and make sure that if there is any that the cornea involvement is being documented in that slit lamp exam. I'm sure, if there's any there,
is.
Yeah. It could be a myriad of things, depending on how long the lash has been there. And our impression, our diagnosis is going to be trichiasis. And with the trichiasis, when we do that we need to show how many lashes, unless it looks like that. And we're not going to count lashes. That's ridiculous. But you can put too many to count, or numerous lashes or whatever. But if you did one on the upper right and there's two on the lower left, then we need to just state that in the chart. And any corneal involvement again. So, and make sure you put that at diagnosis. If they've got SPK, we want SPK down there, because that could be related. If they've got an abrasion, we want abrasion down there. So make sure you get that in both places.
If they don't actually have current, if they don't actually have current corneal involvement and they don't have symptoms, if we see that it's something that could become that.
Yeah, I will talk about that here in just a minute. So, and I added this in here because there's a little bit of a confusion on how to diagnose trichiasis. So we have two options. We have trichiasis without entropion, and then we can have a trichiasis with entropion. But if they have an entropion, there's not really a code for that. They may have a trichiasis and entropion, but we only bill entropion because the only actual code for trichiasis is trichiasis without entropion.
Yeah.
So if they have trichiasis and entropion, we only code the entropion. We're gonna have to write in trichiasis. I mean, we're gonna have to freehand that probably, because if we put that trichiasis diagnosis on there, we're telling the insurance company that they have and don't have an entropion.
So it's like
So-
the type 1 diabetics, the assumption is they're on insulin. If you have entropion, the assumption is you have trichiasis.
Right.
So that's why.
Yeah, it's unfortunate that ICD-10, well, actually ICD-9 was the same way, but
I guess that makes sense because if, the only way you don't have trichiasis is if you don't have eyelashes. If you have entropion.
that's true. True. So it's either
One
trichiasis
or
or entropion, basically, those are our choices,
Okay.
one or the other.
Well, thanks for clarifying that.
Yeah, but if they have trichiasis, we do need to add that to our impression, but just not as its own diagnosis. It just needs to go in
The
with the
entropion
entropion.
diagnosis.
Because there's no way to put it on there as a diagnosis without telling them that
So,
they don't have an entropion.
In that scenario, if we build the entropion and put with trichiasis and then epilated 3 offending lashes on the left lower lid, that we can build the epilation as well without any concern or issue.
Yes, we
Okay.
can get epilation paid with the entropion
Okay.
diagnosis.
All right,
so-
thank you.
Let's see here. So our treatment plans are gonna look very similar to the other one. They're drops, epilation with forceps, and sometimes we may have to give them medication. Make sure all of that gets, whatever pieces of that get in the chart. And so let's talk about when there is not that we don't have any complaint, but the doctor sees that they have a lash that is threatening their cornea. I mean, you got to do something about it because eventually it is going to cause problems. Well, we don't have a chief complaint because it's absolutely not bothering the patient at the moment. And that could be for a myriad of reasons. They could not have any sensitivity in their cornea anymore either. So, and we could be looking at an ulcer in a week, so we got to make sure that we do something about it. We can't just leave it there, right? So, in the absence of a patient complaint, there needs to be a patient-doctor discussion documented. So what are they going to discuss? They're going to discuss the cornea issues that they're having that they didn't know they were having, or they're going to discuss the possible consequences of having corneal problems in the future and the risk and consequences of not treating this. If we don't treat this, you're going to have an ulcer. If you don't treat whatever the doctor says, that's what we need a doctor-patient conversation documented. And then we need to definitely say that the patient has agreed to treatment. It could be, and I saw this in a chart the other day, and I want to jump up and down and holler. The patient had no complaints. One of our doctors noticed that they had an errant lash. They discussed this with them, and the patient said, "Oh, you know what? I have been having some scratchiness," and they put that in their impression and plan. I was like, "Yay! We can bill it!"
Even if it's not on the chief complaint page, as long as you're documenting it and your impression plan,
Yeah, I mean,
In
it's
that
got to go
scenario.
somewhere. Yeah.
not for cataracts, but in
Yeah,
that scenario.
Yeah, in this scenario, it's perfectly fine to say patient told Dr. Mayer they were having they've had scratchiness for a few days. So, that's perfectly permissible. There's no rule that says it has to go in the HPI. It just has to be in the chart. It's preferable that it's in the HPI, and if you want to go back and put it in the HPI, that's awesome. It does not have to be as long as it is in there. So let's just get it in there somehow, or get that doctor complaint, doctor discussion. And if we need to set up something on a pick list for that, what is it, a quick plan? If we need to do that, we can, but, okay, but we're not going to. So anyway, but we do need to have that documented, and then we're okay. So, so the key is to document. We have to document all of these things, especially when there's no chief complaint, and doubly if there's no corneal involvement yet. But again, we have to take care of the patient. That's our first priority. So let's just document everything we can. If we don't document it, we can't bill it, and we're just throwing money out the door. So, because if they're gonna do it, they ought to get paid for it. There's gonna be times when they're not, but let's get as many of these paid for as we can, because they're spending time doing it, and they're spending time talking to the patient about it. So let's get them paid for that. Yes, ma'am.
Do I have to put like the specific risks, or can I just put risks?
I'm sorry.
No, you
The
can
risks
put risks
also
reviewed.
listed. I
That's
have
fine
to-
for OMIC, yeah,
Okay.
putting risk review. You don't have to say specific
All
risks.
Yeah.
Yeah,
Yep.
good question, yeah.
Yep. Okay.
That's more of an OMIC question than a billing question.
Yeah.
so, yeah.
So, any questions that we haven't already asked?
Actually,
Go
quick
ahead.
question.
Yeah.
So back to the trichiasis, we have doctors that will occasionally waive the charge for plugging out an eyelash. What do you want us to do in that case? Definitely still code for trichiasis, of course.
Right.
But so you put in the plan, like charge deferred by doctor or anything like that? Or?
I would put NC on the route slip
Yep.
Okay.
by the epilation section.
Yep.
But you're absolutely right. We
Yep.
still want to
That's a good
document
point.
the lash was epilated, etc.
Mhm.
You know, it's really sad to say, but we live in a very litigious world, so we need to document everything we do.
Yep.
So even if Dr. Smith, he tells me sometimes, don't worry about it, I just don't document it, it's fine. No, you document it.
Yeah.
Yeah.
Yeah, whether we're gonna bill something or not, we have to cover our doctor and make sure they're documented.
I didn't realize that it was
So
still
no.
coming. Yeah. I'm sorry, did you have a question?
Yeah, I have a question. So this came up, I think, last week. It's one of those gray area billing questions, which happen a lot. So patient comes in for treatment. It's a chalazion, and Dr. Smith just decides to put some pressure on the chalazion at the slit lamp, takes the time to express some material at the slit lamp. Now, I can't charge for an excision in this
Right.
point. How do we code that so that they get paid appropriate?
It's an office
part of the
visit.
It's an office.
Yeah,
visit.
and one
You
of these.
Okay.
Thank you for
You
taking
can't
care of
code
your
for that.
patient.
Yeah,
Yeah, okay,
because of the
okay.
additional time, there's no, it's just like if he were to flip the lid to look
Yeah.
for a foreign
Yeah.
body underneath the
Okay.
lid, there's no additional charge because he flipped the lid.
Got it.
It's kind
Because
of
I
him
can
just
ask
taking
Dr.
time
Smith
to try.
sometimes, they're like, I don't know, just, you know, like simple this.
no.
And it's
Yeah,
like,
it's just the
okay,
appropriate
I'd like to
E&M
know.
code usually.
Yeah.
Okay.
Yeah.
All right.
Or could even be an intermediate I code at that point, because we do have an
More
issue that
doctor
we're dealing
time.
It's
with.
kind of
Yeah.
like
Okay.
suture removal is part of the exam.
Okay.
It's not something that we can bill as a
Yeah.
foreign body removal,
Mm-hmm.
because most likely we put it there, so.
And we
So-
would also look at it as like a preemptive thing, so we don't have to then take the additional 20 minutes to do an actual excision. If he pops
Okay.
the zit and it works, then we're good.
Yeah.
You know, so he's actually saving himself time in the long run,
Right.
so
Mhm.
we don't code for that.
Just the office visit.
And then one more question, if no one
Sure.
else. When do we go from a level 3 follow-up to a level 4?
There would have to be something something worsening at very least, more than one thing worsening. If it's an established problem,
Okay.
obviously it is because we're following up on it.
Right.
They would have to have a major, like, well, number one, to even get a 3 on an established problem, you have to have something worsening. To get a 4, it's hard on an established problem if it's one problem. It would have to either be more than one problem, I mean, legitimately more than one problem, and it would have to have some kind of major exacerbation
Okay.
happening,
To go.
or we're taking them to surgery or something. But an established visit, it's hard to get upper levels on if you're just on an established problem. If there's just the one problem.
Okay.
So theoretically, the reason why is because you've seen this patient a number of times. It's not brand new, so you don't have to assess it from start to finish.
Right.
The doctor should just be going in, like with her pressure checks, going, oh, looks good, see you next time. Or, let's dig and let's hunt. And
So I've always been told a pressure check is a level 3.
currently at this practice, it
Yes,
is.
yes.
Okay. All right.
Yeah, but if their pressure's 30 when they come in here, then and we have to do something about it, which
Mm-hmm. Like
probably
change your
are.
medications
And
or something.
that's a different story. So if it's a chronic problem like that, that's a little bit different. So if we're following up on a chronic problem like glaucoma, and that turns out to be a they come in with pressures of 30, and we have to change their regimen, change their drop, or do something about it, or replan surgery, or whatever we're going to do. Then that possibly, depending on how much you document, could get it up to a 4.
Okay.
Medical decision making wise, we could stretch that into a 4.
But it has to be more than discussed, we'll continue to monitor, or
Right,
discuss,
right.
change
Yeah.
med,
Yeah,
you
We
know,
have to
it
be
has to
actually
be
doing
risks
something
and,
about it.
yeah, counsel patient for 20 minutes or
Yeah.
whatever the situation may
Yeah.
be. It can't just be your little pick list.
if it was a follow-up on something that is a little more straightforward, like an abrasion or something like that, that's not chronic,
Okay.
then we're not gonna get it to a 4. I mean, it'd have to turn into an ulcer and we've gotta do something about it
I mean, you
to
could
get there.
theoretically
you know,
stab them
so.
in the knee with your pen and that would get it.
Okay. In the interest of.
Don't
guys,
do that. In the interest of your job, do not do that, Curtis. Does anybody else have any questions for the billing department?
What about resolved? Like, I've heard a couple different things about funds. If they come in, we put them on something and then they come back and let's say if the symptoms have resolved and we'll just see them when we see them. Is that still just a 2-1-3?
It's just a 2.
Mhm. If it's resolved and you're not seeing them for anything else, legitimately not seeing them for anything else, then it's a very low level visit.
That's what I think.
Yeah.
Yeah.
So cool.
Yeah.
Right.
They've already been diagnosed, they've already been treated, that we're just basically letting them
That's
go,
all
that's
I
not.
I've
That's
never
just-
used a 1-1
A
or
1
1-2.
is only if it's a tech exam.
So
No
technically
doctor
we could
involved.
bill
So
if
contact
a
lens
text
is
saw
probably
the patient.
good.
So we never bill level 1s because level 1s are an auditing nightmare. If we start billing those, they're gonna get onto
Yeah,
our
those are-
case.
Got it.
Those are almost looked at, probably actually more often than a level 4 or 5. So we're very careful about billing
It's
those.
like the patient.
Because that
gets
makes, if you
dilated
bill those very
start
often, it
eating.
looks like you are intentionally undercoding.
And if you do ones all the time, it looks like your techs primarily are seeing your
Right,
patients
right,
rather
and you don't
than
want,
the
you don't want
doctors.
the,
And
for
that's a
anybody to
legal
perceive that.
nightmare.
So we do a comprehensive exam and they're not dilated, you want to put it as a 1-2.
Say that again?
No,
For
the doctor's still
resolve.
seeing the patient.
But they're not dilated.
If the doctor's seeing the patient and they're not dilated for a comprehensive exam,
Yeah.
that's an intermediate.
Yep, that's the 1-2.
9201.
Yeah, 92012.
I think we're talking two different codes.
Yeah.
Yeah, I'm
Yeah.
still right here.
Yeah.
92012. If they're not dilated.
I'm talking about for
Period.
resolved.
She's talking about
Yeah, I
level
know.
two.
I got her.
Okay.
I'm just
So-
Cool.
Alright.
Do we have time for one more? We had
Yep.
this conversation real quick the other day because I had done a dilated exam. So after cataract surgery, Dr. Smith will dilate 3 to 4 months out. From my understanding in that conversation, I want to know if this is correct. If ancillary is not done, you can't code it as comprehensive. If ancillary is, you can. Is there any truth to that? Or if we're doing that dilated exam without refraction, it's just
Okay.
comprehensive without refraction? Because techs are
Say
coding
again.
it different ways.
I don't.
So like some techs aren't doing all the ancillary stuff. Some don't do any of it.
They just come in and
vision
check
pressure
pupils.
and then dilate them.
Oh, okay, so we're not doing EOMs, we're not.
No.
Exactly.
Or,
That's
or
what I'm
like a
saying.
4-month
Ancillary
after
is not
cataract
Okay.
surgery
How
Yeah,
situation.
does
that's not a comprehensive exam.
Okay.
You have to do, with
Everything.
in our MAC area with
Yep.
Medicare, we have to do every exam
So
bullet
that's
to get a
falling-
comprehensive.
falling
exam.
under
I
level
think our
3.
protocol says we do ancillary.
It does say it, but
But
Okay.
we come
there are
across
times
these
when
things.
people pick and choose what they want to do,
Okay.
and they're not always getting done. So
And I just
But
clarify.
technically, that would not be a comprehensive.
Right. We'll
Correct.
remind people of their protocol.
Well, so that's
If
what
they
I'm,
have
that's what I'm
everything.
getting at. If they have everything, then
they
it
have
is
it, but
dilated.
if they like looked at pupils
Yeah, that's it.
and looked at my telly and then do the one in between, you can't
Yeah.
code it.
Okay.
You know?
It's the elements of the exam there.
Yep.
Yeah.
Yeah, makes sense.
So, any more
Oh, one
questions?
more.
Okay,
Yeah, no.
okay.
So when he has
Good
Dr.
for you,
Smith
Doc.
and he does like a Chalazion, he codes like, what do you usually code? A 1-3 over here? And then-
Yeah, because they're coming in for treatment. So Dr. Smith will do a same-day chalazion removal. So I'm coding a level 3
Okay.
because it's set as a treatment. So when they come in, I'm already working on this page, according to what they're being seen for. And then I'll also code down
minor
here.
procedure.
Yeah, the minor procedure.
Were they,
chalazion single.
were they coming in specifically for the chalazion, is that what I'm understanding? They're not?
They were coming in for the chalazion symptom,
So
for the issue.
for a
But they're
treatment, not a
coming
minor
in
surgery.
for a treatment and not a minor surgery. So he's basically, in essence, doing a consult and or not a consult, but a visit, and he's
Okay,
going,
so
I'm
is
gonna
this-
save you a trip, and I'm gonna go ahead and excise this today.
Okay, so this is the first time he's seen them for the.
Correct.
Okay, yes, then if they have not already been diagnosed by a partner in this clinic, so Dr. Cheney hasn't said,